Well, I will not kill you by PowerPoint, no worries. I will not feed you instead of having lunch with a lot of literature. I recommend 3 papers that you should get in your mind. That's 1 Nature paper, 1 New England Journal of Medicine, and 1 Lancet. That's it. I should talk about a very emotional topic. Very, very emotional. I tell you why. Because we are talking, we are communicating with payers that will tell you we don't have the money. We are talking to payers that spend $2 billion a day for military expense. We are talking, and I personally, we are talking to ministers of Middle East countries that has the highest expense for military, where they tell we don't have the money for economics, for our health. So I remember 22 years ago, I had a conversation with the biggest insurance company in Austria, Gebietskrankenkasse. I took all the literature, and that time I had around 400 or 500 papers with me to the director, to the medical director of the insurance, and I said, I'm doing surgery for massive overweight people, and I would like to see that the insurance is paying for that. Guess what he told me? He didn't say, I don't have the money. He said, Dr. Miller, I can read. All what I want to have is communication with you and with your surgeons so that we can find ways who is eligible for surgery, who will benefit out of it. And since that time, bariatric surgery was funded and covered by insurance and by government in Austria if the indication is right. So they wanted to see the patient before surgery with our recommendation letter. Guess, we were one of the first countries worldwide got funded for this kind of surgery. And last year, I had a meeting with the biggest insurance company in Saudi Arabia. As I mentioned in my disclosure, I also consult Johnson & Johnson as Chief Medical Officer for Middle East. And I started with this question: what if? What if you can reduce your expense for diabetes patients about 10%? That was unexpected. He didn't expect this question. He didn't expect this slide. He expected that I overfill him with a lot of data, a lot of literature, a lot of studies. I did not. I said, what if? And you know that diabetes is one of the biggest health economics problem, one of the burden in our society. Because it's not only an incurable disease, but the prevalence doubled and is increasing. And with all our best treatment, we have increasing numbers of diabetes. And 1 out of 2 adults with diabetes is undiagnosed. And not only that, less than 1% of those patients will have really sufficient treatment. Very, very emotional, I tell you. So what are the biggest cost driver for insurances, for governments on disease and disorders? It's diabetes, it's heart disease and stroke, it's cancer, and it's obesity. Those are the 4 major cost drivers of your health expenditure. And yes, you can put numbers, figures, how many billion will really suffer and pay for that disorders. Diabetes, stroke, cancer, and obesity. And it's not that insurances and the governments, they know this. It's not that you have to tell them this. They know this. So I don't have really accurate data for Brazil, but as you see that in between 9 and 14% of your population are diabetics. Those are really enormous cost drivers. And that's a prevalence measured by oral glucose tolerance test. And diabetes is also super expensive in Brazil. This is what I got on data, that it's $65 billion in Latin America and 22 billion in Brazil. Direct and indirect costs together. And the excess cost really exceeded about 300%. So this is something that is at the moment the picture of uncontrolled. So as I summarize, it's a global emergency. It's one of the leading causes of morbidity and mortality globally. So all what I tell you is based on a bunch of literature, mainly from the Diabetes Federation, mainly from the Global Diabetes Report, World Health Organization, etc. So it's the leading cause, no question, we all know that, of limb amputation, kidney failure, and new cases of blindness. So diabetes. But when it comes to the topic, what I should also emphasize, it's what is the relation to obesity? Diabetes and obesity are more or less brothers. 1/4 of your obese patients are suffering from diabetes. The majority are undiagnosed. When you see them the first time, in my practice, 20% of the people I saw first time never had any idea that they suffered from diabetes. Obesity is really a major risk factor developing type 2 diabetes, but the average BMI worldwide for type 2 diabetes is 32. So they have the risk here. Not here, it's exactly here, in the central of your belly. So 80% of your type 2 diabetic patients are either overweight or obese. So that's really a nice fact, with a perfect conversation to your insurance, to your payers, to your government. So how can we get this? I want to reduce the health expenditure in your diabetic patients. How can I achieve this? Well, look on your guidelines. The American Diabetes Association had a really perfect standard of medical care for diabetes. Published every year, updated every year. The last one is now available on the internet for free. So they have really a perfect algorithm how you should treat your diabetic patients. And I tell you, this algorithm is not cheap. But in the algorithm, you will not find really easily, in the old one, surgery. And I remember with the Diabetes Association in Austria, I had a conversation a long time ago, it's more than 15 years ago, where I say, before you prescribe insulin, only offer surgery, metabolic surgery, just offer. And I say, no, we need more paper. We need more data. Now we have 11 prospective randomized controlled trials, and I still have the same conversation. No. Sometimes you think you are talking to illiterate. But those are colleagues, those are studied, those are doctors, and they do not send you the patient. So, thanks to Francesco Rubino and his co-workers, they started bringing the majority of physicians together, endocrinologists, internists, and looked on what evidence we have on diabetes surgery. And they called it Diabetes Surgery Summit. And they tried to find a consensus and develop a global guideline regarding surgery on diabetic patients. Now it's getting super exciting because, as I mentioned, you don't need to have a lot of papers, but one of them is coming here. That's the New England Journal of Medicine paper, where it shows the best medical treatment compared with bypass and sleeve gastrectomy in diabetic patients, prospective, randomized, controlled, and monitored. And this is something which we really want to emphasize. You will read a bunch of papers where they say it's randomized, a randomized study. But if you don't have a monitored study where someone independent is coming, looking on the data if they are really correct, what you put in your database. And that is impressive. With the best medical treatment, after 5 years, you have not really a very impressive change in your hemoglobin A1C level. But in that time, in those 5 years, you spend a lot of energy, a lot of money, a lot of medication in these patients. Fair to say, I really have to clarify that, the bypass and the sleeve patients, they achieved really significant reduction in HbA1c, but the sleeve patients need more medication to achieve this compared to the bypass. So that is really something you have to read a little bit more in the small lines of your paper. And the New England Journal of Medicine divides a little bit more clear in the diabetes, in the medication. And when it comes to the medication, you see on the conservative treated group, nothing changed significantly. Yes, insulin is a little bit reduced, but on the other hand, the modern glucagon-like peptide analog are increased, etc., etc. The people who could control the diabetes by best lifestyle management didn't improve, still less than 2%. So basically, the best medical treatment is not really impressive when it comes to health economics compared to sleeve gastrectomy. So the insulin, which is the 45% before surgery, reduced to 11%. That's highly significant reduction on insulin. Or even more impressive in gastric bypass, where 45% of the patients after 5 years didn't need a medication. So most probably that is a very impressive paper showing the endocrinologist, oh, I will lose my patient. And where I'm working in Middle East, they are sitting on their patients. So physicians are not giving their patients to another physician. And this is what we have to learn to teach and train our colleagues, that they will not lose their patients. It's quite the opposite. They will have now a patient who is really eligible to treat. So a surgical patient with diabetes is easier and better treatable, so therefore you will not lose your patients. And this is impressive. If 75% of your patients will not need insulin anymore. So this is something we mentioned New England Journal, and here we have the Lancet paper. So all about how you define your normal glycemic level. Is it 6.5 less, or is it less than 6? You will have even better outcome. Where you see after 5 years with Roux-en-Y gastric bypass, 79% don't need any medication treatment so far. Or even with biliopancreatic diversion or duodenal switch procedures, you have a 95% of reduction of your insulin. Or 95% of your patients don't need insulin. So those are really impressive figures. But even, and that's the third, the Nature paper from Francesco Rubino. He took patient diabetic who had insulin. And after 5 years with gastric bypass surgery, you see yourself. Compared to those who had no surgery, they even had to increase their insulin within those 5 years. So no surgery, insulin increase. That's a message in Nature, which usually we as surgeons cannot publish. We don't get a paper in Nature. Only Marusco, when he did a transatlantic operation, and Francesco Rubino with this impressive randomization. Insulin patients getting surgery or don't have surgery. And I tell you, insulin is expensive, and it's getting more and more expensive. So this is what insurance and payers will understand. This is what insurance will listen. Oh, no insulin. Insulin is getting more expensive. And in addition, I have a question then to you. The question will be, what if? What if you develop a medication in cancer treatment that has this figure? Here. Survival with the very expensive chemotherapy in whatever cancer patient. You will get it immediately on the market. You will have it immediately on your guidelines in the oncology. Why not in diabetes? Surgery versus non-surgery. We have now really long-term follow-up on very impressive survival data, surgical versus non-surgical patients. And this is what insurances really understand, the major cost drivers to best practice. And that is very difficult then to ignore, because the majority of your payers are dealing with emotions. When it comes to a gastric cancer patient or lung cancer patient, you have this medication, prolong his life for 2 months, you will have it immediately. And this is something we all don't understand. But let's get back to the Diabetes Surgery Summit, which is now accepted. The guidelines of this summit, where 75% of the people sitting in this auditorium, in these guidelines, were non-surgeons, and endorsed by 51 medical societies, not surgical. You will have the American Diabetes Association, the International Diabetes Federation, etc., etc. Those societies endorse the following guidelines. The following guidelines are, as you all know, surgeons you know, but you have to give this information to the public, to the payers, to that what we call stakeholders, insurances, governments. And I think you are the leadership, really are responsible to deliver this information to those stakeholders, to consider and to recommend metabolic surgery. Based, yes, for obesity. So if your patients are uncontrolled in their diabetes with a BMI over 30, and for Asians, 27.5, those are considered, bring them or offer them the possibility of metabolic surgery. Class 1 obesity, consider metabolic surgery as the guidelines from the American Diabetes Association. So the economic impact is enormous what diabetes is concerned. That's no question. It's 9 to 10% of your total health expenditure. And yes, your medical expenditure for patients with type 2 diabetes is up to 4 times greater than for obese patients without diabetes. All that is no surprise. But the problem is, yes, what you will have on conversation with payers, that at the beginning you have surgery, that's expensive, that we cannot pay. And next year, another director is sitting on this, and I have to give my year-end report, which has a lower expense. You are confronted with this kind of conversation. But on the other hand, you can ask, what's your expenditure on other disorders where you don't have this success? Therefore, you have to learn a few vocabularies. There's ICER and QALY, the incremental cost-effectiveness ratio. So basically, that's the cost-effectiveness of a healthcare intervention. And the quality adjusted life year. It's used usually to assess the value for the money of medical interventions. That means one QALY is 1 year of best health. How much are you willing to pay for that? I give you the example, for gastric cancer, it's around $50,000 to $60,000. Kidney transplant, I don't have the figure in mind, approximately the same, but dialysis, $40,000 a year. And now we are talking about $7,000, $12,000 compared to best medical treatment. So we do have a bunch of publication where we really can demonstrate and show cost-effectiveness ratios. The only problem, you cannot take the cost-effectiveness ratio from UK and go to your payer, go to your insurance. But you can have and start a conversation, and that was super successful in Saudi Arabia with Bupa, the biggest insurance company. They do have the data. Collaborate with your insurances, collaborate with those who have good data. They have it, they just don't know what to do with it. You have the data of the effectiveness of surgery. Really good data. And you can collaborate with the data from the insurances. They know exactly how many limb amputations they have. They know exactly how many dialysis they have based on diabetes. Just in Bahrain, where I was recently, they had an increase within 5 years from 100 dialysis to 300 dialysis a month. Diabetics. So look and search for conversation. Although they will have a communication with you that cost effectiveness, pro, contra, yes it is. It all depends what you're looking on. But you can say, those who don't find that bariatric surgery is cost-saving, healthcare cost will increase, yes. If more individuals receive bariatric surgery, but the increased cost appear to be offered for a good value. Does anyone ask for cost effectiveness in cancer? That was a very, very provocative question to the insurance head of. They don't ask. They just look on the studies and on the pressure that the Oncology Society will put on them. And of course the public. So it's really up to you how you can drive a very proper conversation with those stakeholders. We know, and that's my last slide, no worries, we have lunch soon. We know that diabetes is increasing. Accordingly to the Diabetes Association and the International Diabetes Federation, it will be triple in 17 years. So we are confronted with an avalanche. We have surgical guidelines, we have guidelines, we need to transport them, we need to communicate them in a proper way. Those guidelines are endorsed by 51 medical societies. And I think it's really time. It is time that we think differently about diabetes and obesity. So thank you very much and looking forward to meeting and discussing.